Hello, everyone. Today, we move on to the next aspect, which is fluorescein angiography in retinal vascular diseases. We've already seen the diabetic retinopathy and all its manifestations in terms of the fluorescein angiography, and today we will look at all the other vascular conditions. The most common being retinal venous occlusion, and that's mainly the CRVOs, PRVOs, and the venular occlusions. Basically, the elevation of venous and capillary pressure causes stagnation of the blood flow, retinal hypoxia, and then damage to the capillary endothelial cells. And then there's extravasation of the blood constituents and, of course, the mediators like VEGF, which come in. And the anatomical basis is all because of chronic atherosclerotic changes, inflammation, mechanical compression of the venule at the crossings. The crossings are predisposed to these blockages, luminal narrowing, and the secondary vascular impact. So this is a classic picture of a vein occlusion that you see with hemorrhages spattered all around, disc edema, dilated tortuous veins, and then when you do the angiography, you may see delayed filling to some extent, and then some masking by the hemorrhages that you see in an early phase. So grossly, when you look at CRVO on an angiography, you could kind of classify it in terms of ischemic and non-ischemic, but this FA happens after a few months of the condition. So here you can see that you could call this as a non-ischemic because the overall perfusion seems quite nice and well and is not compromised at any particular area. While if you look at this particular CRVO, you see a lot of capillary non-perfusion areas greater than 10 disc diameters, and we call it ischemic. Of course, clinically, you also label them ischemic, non-ischemic on basis of the presenting visual acuities and a lot of other factors which are there. Early stages of vein occlusion has a lot of hemorrhages which are scattered, and the angiography is of not much use because most of the fundus has got a masking because of the hemorrhages, and you may not get information about capillary non-perfusion, which is what you're looking for in these cases. So this is again a classic non-ischemic CRVO. You see changes on the OCT to some extent, and then you see the generalized tortuosity dilatation of vessels. And when you do the angiogram, you will see a delayed transit time and sluggish flow, and various areas of where there's hyperfluorescence happening because of the edema, and then areas of partially blocked fluorescence due to hemorrhages, and then you're looking for any onset of ischemia. Once again, you see a OCT which has got chronic edema. Nowadays, we look at the OCT to diagnose the edema, and the angiogram is only going to give you other information in terms of ischemia and associated findings. If you're looking at a classic ischemic CRVO, the OCT will show thinning, and then there's marked delay in the transit time, which we saw in the earlier angiograms. And these occlusions would have poorer prognosis and may also require lasers along with the anti-VEGFs that we use typically for other CRVOs. So the vision loss is due to the macular ischemia or the chronic macular edema, and then there can be secondary neovascularization, which is hemorrhage, fractional detachments, which have its own consequences in the long run. This is a patient of an old CRVO. You can see sclerosed vessels. You look at the angiogram and you'll see a lot of capillary non-perfusion all around. Even the iris, you can see the NVIs, which are hyperfluorescing on the pupillary margin in these cases. They require extensive treatment in terms of anti-VEGFs and lasers in multiple settings. Hemiretinal vein occlusion acts very similar to a central occlusion, except that geographically it will be located to a superior or inferior half, but all other parameters in terms of diagnosis or management remain pretty much the same. This is an inferior hemiretinal vein occlusion. Coming to the branch vein occlusion, it will be usually one geographical half of the fundus that is usually affected, superior, inferior, and here you see changes that are taking place in the superior fundus, and you can see the OCT angiography changes, which show these small circular petalloid areas of the vessels which have formed with chronic BRVO here, with non-perfusion areas seen And if you look at the OCT, these changes are seen just over the hyaloid by this kind of a hyper intense areas which are seen here as it make an interesting picture in BRVOs. So the major BRVO blockage in arcade vein causing impaired drainage across the entire quadrant of the retina. Most common is the supratemporal quadrant, which has the maximum AV crossings located. So the features are, of course, some in the early phase it will be masked by hemorrhages, and eventually you look for ischemia. You look for intraretinal hemorrhages, collateral vessels. As you can see, all this establishment is there. And if you are trying to laser this, you should leave the area of collateral activity alone because that does help to some extent in keeping the macular perfusion on. This is again infratemporal BRVO. You also see hemorrhages and these whitish exudation, which can be there in the acute phase, which clears up eventually as time passes. And then you look for any ischemic areas which could be left behind. This is a supranasal BRVO showing sclerosed vessels and corresponding non-perfusion areas which are seen. Here, once again, an old BRVO with an area geographically demarcated with non-perfusion areas, capillary non-perfusion, vessel pruning, and this will require laser along with the anti-VEGFs. Development of the neovascularization happens with time, and it's something that you have to look for to prevent further deterioration with hemorrhages and tractional retinal detachments which come up. Sectoral laser for neovascularization is done. You can see the laser marks here, which are showing some sort of regression in these cases, and you have to use them in adjunct with multiple anti-VEGFs. This is the FA appearance after a sectoral laser photocoagulation. A minor branch retinal vein occlusion looks something like this. It is located within the arcades and will take this kind of an edema on the OCT. And when you look at the FA, you'll see the fine venules which are affected. And these, even though it's a smaller area, but this is quite a notorious occlusion and keep giving anti-VEGFs and they keep coming back to you again and again. And the only treatment is repeat anti-VEGFs, or at sometimes chronic edemas, we give Ozurdex or a steroid also, but they are quite notorious at times. The early venous phase, the late venous phase, and the recirculation phase of a venular, small venular occlusion that you see. Then we come to the retinal artery occlusive disease. It's basically triggered by an emboli formation of a cholesterol, calcium, or a fibrin, which starts this whole cascade, the ischemic cascade, and causes extensive edema to the area after a blockage, and the damage happens within a few minutes. The result is a cherry red spot sign. The retinal whitening happens around it, leaving the central macula looking like a cherry red in most of these situations. So this is a branch retinal occlusion. You see a geographic cutoff very clearly seen. They will always take a geographic horizontal cutoff, these arterial occlusion. The OCT will show you a lack of differentiation of retina in the affected half as compared to the normal half, which is there. And when you do the angiogram, you'll see sometimes a delayed filling or a total lack of filling in that area based on how the reperfusion has happened post-occlusion. You can see that quite clearly here. This is a BRAO with an impending CRVO. You also see associated tortuous veins. So at times these ischemic phenomena are accompanied with arteries and venous involvements that you see here. Central retinal artery occlusion, classically, you see the classic edema which has occurred, and you do the angiogram and you see a very dark area here that is seen in the macular area, which suggests that there is an extensive ischemia in the central part. Now, this is a CRAO with a cilioretinal sparing. You see this whole area which is spared from the ischemic area, and you look at the angiogram and you can understand why, because that's the area what well, some patients have cilioretinal artery and that supply is still on, and sometimes patients have this central window of vision while all the rest is destroyed, and this is the angiogram accompanying that. CRO with sparing of the papillomacular bundle, again a similar situation, cherry red spot, and this sparing which is seen, the OCT looks like this. And when you do the FA, you'll see that the perfusion is totally hampered. It doesn't go beyond the central area, the perfusion, the supply of the cilioretinal artery in the papillomacular bundle. CRO with a sparing of inferior macular area that you see as a perfusion. Look at the angiogram only in the whole fundus. This is the only area which is perfusing. So starkly the angiogram picks up and guides you about the perfusion. And some patients come with only cilioretinal artery occlusion. So you see only this particular area is occluded. You see the OCT changes of lack of differentiation. This is again another similar case. And look at the angiogram where you see a total filling defect defining that space of total occlusion. Then you come to ocular ischemic syndrome. Now, these are straight dilated veins. They don't show much tortuosity, arterial narrowing, few hemorrhages, and hard exudates, edematous disc. A very fundus which is featureless to a large extent. On fluorescein angiography, you'll have prolonged arm retina time. Early phase has delayed choroid filling and prolonged arteriovenous transit, and the late phase has optic disc kind of hyperfluorescence, a hot disc, and perivascular fuzziness, which can be seen in these cases typically. So how do you differentiate ocular ischemic syndrome versus a central vein occlusion? Difference is in vessel staining on the fluorescein angiography. The retinal arteries stain more prominently if you're looking at an ocular ischemic syndrome, while if you look at a CRVO, it impacts the venous drainage, much more tortuosity, and much more action seen on the angiogram. While the ocular ischemic syndrome, the FA will be a little more silent except for the hot disc, which is seen quite well. Hypertensive retinopathy can have many features, and if there's malignant hypertension, there'll be extensive edemas and all, but otherwise you may just see arterial narrowing at the AV crossing changes, capillary non-perfusions localized at times, choroidal infarcts at times, the cigarette spots, late phase leakage from damaged vessels, and of course optic disc leak. All these could be seen in some aspects of hypertensive retinopathy. Anemic retinopathy, which also leads to these kind of hemorrhages, which are blotchy, very different looking than what you see with the venous occlusion hemorrhages, and at times you see rod spots also and blotchy hemorrhage, multi-layered hemorrhages with typical rod spots, mass background fluorescence. Changes typically seen in severe anemia, often with hemoglobin less than 8 grams. Leukemic retinopathy, again a blood dyscrasia causing hyperviscosity, can lead to multiple hemorrhages, rod spots, and varied kind of findings, at times macular edema, angiography showing you leakage, tortuosity, and late staining of different areas of the fundus. Sickle cell retinopathy leads to neovascularization. C fanning is the classic sign described. You can see it here. All these are cases of sickle cell where you see the C fanning happening at the junction of perfused and non-perfused areas, and they lead to extensive hemorrhages, tractional detachments, and they need aggressive treatment with lasers and anti-VEGFs. Retinal artery macroaneurysms. You can see here there's a macroaneurysm which has caused a hemorrhage. Macroaneurysms can lead to hemorrhages actually in all the three planes, subretinal, in the intraretinal plane as well as in the subhyaloid preretinal plane. Here you see a subhyaloid hemorrhage which has occurred and has led to a hemorrhage as well as a lot of exudation which is coming on the angiogram. You can confirm the site of these macroaneurysms which are there. Here you see, in this case, a lot of exudation around this aneurysm. FA picks up the exact outpouching of the area which fills up for the macroaneurysm which is there. This is again the macroaneurysm you can see here. And when this is the lasered, after the laser that we have blanched that area with the aim of reducing the leakage and also give anti-VEGFs to clear up the macula, which has already got some exudation in that area. At times, Valsalva retinopathy, which is sudden rise in systemic and local ocular venous pressure due to the Valsalva maneuver, ruptures the perifoveal capillaries and leads to premacular and intraretinal hemorrhages of varying severity. So Those are again, an angiogram can help you differentiate the planes of these hemorrhages quite well. There is a case of Valsalva where you see these multiple levels of these hemorrhages which have taken place. If you do the angiogram, you will see clearly a masking uh, in this area by a subhyaloid component, and here there is partly which has got a subretinal component or intraretinal component, which is over which the vessels are seen passing through. Now, pediatric retinal vascular diseases, sometimes also angiography can help, although it has its own challenges because of the age of the child. Uh, Most commonly in retinopathy of prematurity. A lot of retinopathy of prematurity is diagnosed clinically because it's meant to be clinical diagnosis and different stages are defined, and on that basis, early laser or at times anti-VEGFs are given to treat these patients. Fluorescein angiography accurately demonstrates the junction between vascularized and avascular retina. Vessel characteristics seen much more clearer than color images, and they help define the stages. So these are some examples of angiograms taken from ROP babies where you see the junctions very well. Arteriovenous shunts are seen in some situations. Capillary tufts and popcorn lesions, which are described here, which suggest ischemia, which is advancing. Irregular supernumerary branching of peripheral vessels. All these are different features of ROP. The aggressive ROP is rapid pathology, which is got advanced neovascularization and severe plus disease without progression through typical ROP stages. Often have deceptively featureless networks of flat neovascularization, but the angiogram may pick up these changes much more clearer. The predictors of ROP progression: delayed retinal artery perfusion, popcorn lesions, which we described on the FA. You can see these are the popcorn lesions that are described. Hypofluorescent round lesions associated with popcorn-like vascular abnormalities on the color fundus image as well. So these are where FA can be used as adjuncts, and also with so much anti-VEGFs being used, I think FA is a good tool even when you are looking at following up these patients at times that when you decide that should any laser be done or the anti-VEGFs have regressed it enough, and the child can be left alone after just routine follow-ups. Then you come to Coats disease. Now, this is idiopathic telangiectasia that occur in early childhood, usually unilateral in young child, but can also happen in young adults as a variant. So here you see all these changes taking place, cause ischemia, a lot of exudation, and they need to be lasered as soon as possible with or without anti-VEGFs in these cases. This is the venous phase. You see the aneurysmal capillaries which are there, which are leaking and lead to a lot of damage in the long run. You see this deposit of yellowish thick lipids, very classic of Coats. This is, of course, a case of an adult Coats 26-year-old male which had these changes. So one has to always do angiography and then find the leaking spots and laser them effectively. Otherwise, they will keep leaking and cause much more persistent damage. Familial exudative vitreoretinopathy, fluorescein leakage without clinical exudation raises concern for the exudative phase of the disease. These changes occur in the extreme periphery, and at times it has a featureless retina, and you always look for the temporal periphery, but they can be there all 360 degrees also. But the angiography picks them up very well, and it picks up the junction of the perfused and non-perfused retina and the skip areas which are there, and they should be treated always. This is a patient of FEVR. You can see a front of neovascularization in the periphery, which is seen very well on the angiogram that's been done here. And you also look for other areas which might be there, which require more treatment. So the wide field angiography helps a lot for these kind of cases. This is the other eye of the patient, which we are seeing. And if you look at the extreme wide field, you'll see these are the skip areas in the periphery. I mean, the ischemic areas which can, in the long run, form neovascularization and cause further problems. So this is another patient. Both had lasered FEVR, which must have already shown some aggression. We saw this patient in this situation, and you can see that laser marks are there, and there's some fibrotic changes in the periphery, although they look dormant, quiescent. And you do an angiography and you see these changes. A lot of it is laser staining, but the disc still seems hot here, and there's still some changes in the periphery which one needs to follow. The left eye looks fairly benign at this stage, except this small area which is still showing activity and may do well with some more laser augmentations, with or without anti-VEGFs, based on any tractional component that you might see in these cases. Then you come to some vascular tumors. You can see the von Hippels and the hemangiomas that come up. This is a case of a young girl with a large von Hippel hemangioma seen in the periphery with the classic tortuous vasculature that is there of supply, and this is the angiogram of this patient. And we did treatment of this patient in 2, 3 different stages of cryo, laser, anti-VEGFs, and at about 15 to 20-day intervals, 2 or 3 sittings to ablate the feeding vessel, and so that the further growth of this tumor stops uh, as the feeding channel is ablated along with the tumor. So we did a lot of cryo. You can see this is the follow-up, and you see the tortuous feeding vessel and the draining arteriole at this stage. And as we treat this patient, you can see that there's a lot of scarring, laser scarring that has happened. Cryo has been done over a period. And you look at the vessels now. Look at the vessel here on presentation that you see the tortuosity. It's almost blanched because of the laser that we have done over it, as well as the vein eventually. After you've stopped the artery, you can also eventually hit the vein. This is on the follow-up, the angiography that you see here. Look at, compare to this whole tortuous supply and the veins, and this is post-treatment, a second treatment that we did, that the tumor becomes blancher except for some staining, and then the feeding vessel has almost died, and also the draining vessel is almost unvisible now. So your end point is, of course, looking at the eventually regressing the whole tumor and on stopping its channels. And these patients require extensive follow-up, because sometimes the same channels open up on the besides the older one, or sometimes new tumors keep coming up. We call the sibling of this young girl for a routine follow-up. And if you look at the cursorily, you will miss anything on the fundus, but look at this lesion here. He was a young boy with no symptoms, just because of the sister had a von Hippel's tumor, and we called for a follow-up. And look at the angiogram, and it shows you this extremely well. We immediately lasered this case also. So it's extremely important to do angiography for these von Hippel cases at periodic intervals, or any suspicion which is there. If you have missed, there's another small lesion here which was almost not seen on the color picture, and you see this arrow pointing at the inferior part, the another tumor. So this is, in this angiography, is extremely important. This is again another case of von Hippel's, where you see there's some treated von Hippel's tumor, and we do angiography on the follow-up. You still see some persisting aspects to that, and you know that you need to further treat this solitary hyperfluorescent lesion which has come up. And you see increasing in size and intensity with time. It confirms that there is activity and you would need further treatment, and eventually shows you a growth. So this would also require extensive laser and cryo at times if the laser is less effective. Vasoproliferative retinal tumors. This is a case of bilateral retinitis pigmentosa with right eye quartz-like subretinal exudates. And when you do the angiogram, you will see all these changes which have come up. Numerous aneurysmal vascular changes and capillary non-perfusion around the leaking lesion. So this is a vasoproliferative tumor which is there. Then, of course, these are not vascular conditions per se, but an epiretinal membrane which is growing and can cause a lot of stretching and tortuosity. In the past, we used to diagnose finer epiretinal membranes with angiography, but of course, today the gold standard has become OCT, and we rely on OCT to look at diagnose an epiretinal membrane. But of course, the FA will show you a lot of vascular changes as to how much has it affected the vascular component, and will show you these tortuosity and different changes in different cases of epiretinal membranes and associated edema and the leaks which are there. in these components. This is a racemose hemangioma. Now, these are typically dormant. You really have no treatments, but it's best to follow them up and see them. If at all any sign of ischemia shows up, one may use some laser, but otherwise these are to be followed up. So this is a case of a racemose hemangioma that you see in this situation. This is angiography showing you classically the tortuous snake-like pattern of these thick vessels which are going and causing the hemangioma. So these were some of the examples of various vascular situations we saw in the earlier presentation, the diabetic one, and here we've tried to cover all the other vascular situations where angiography has a role in diagnosing at times, and in many of them with how to manage them in their due course in terms of the benefit that the angiography gives you and finally managing them. So thank you very much. Once again, I would like to thank Dr. Shraddha Srivastav, my VF fellow who's helped me collate this presentation, and all my fellows and optometrists who help take pictures of our patients from which we use and put them all together here. And in the next series, we will talk about the choroidal as well as many macular pathologies and miscellaneous pathologies which we haven't been able to cover so far. Thank you very much.